needs no introduction to the group. He is a Director Cardiac Cath Lab at Max and has done more than 7,500 angioplasty and complex procedures, and with a considerable teaching experience during his MD and PG. And recent years he has been a co-guide for DNB thesis, at least in 5 theses. His topic of deliverance today would be related to SGLT2 inhibitors, that is empagliflozin, primarily with respect to cardiovascular outcomes. And the second talk followed, which would follow by Dr. Dinesh Khullar, would relate to renal outcomes. So without wasting any time, I invite Dr. Viveka to deliver his talk.
Good evening, friends. Once again, I would like to thank Viveka and Glenn for giving this opportunity to be with you this evening, and Dr. Chauhan for bringing the group together again on a Wednesday evening. So, as Dr. Sen Gupta has said, that we would be discussing in next 15 minutes or so the SGLT2 inhibitor cardiovascular outcome trials and the outcomes. And because now there is not a single SGLT2 inhibitor, we have variety of couple of other products also. So is it a class effect or all of them are different? So we will look at the similarities, differences, and the implications, because it's very important when we prescribe our patients these molecules. So the absolute risk reduction, that was also very significant, and hospitalization for heart failure was again quite impressive, 35% relative risk reduction, and incidence of worsening of nephropathy, which I think my next speaker, Dr. Khullar, would be speaking. That smaller subset analysis did also show that this is, renoprotective effect was there. So these data was not expected, and you couldn't see many cardiovascular molecules also showing this kind of mortality benefit and reduction in hospitalization as well. And if you look at the standard of care for prevention of cardiovascular death, and we had a lot of molecules which were cardiovascular molecules, and if you look at the, their performance, you could see that empagliflozin and the other anti-diabetic agent, that is liraglutide, they were, giving the competition to the cardiovascular molecule in terms of reduction of cardiovascular death. So one molecule in HOPE trial, ramipil, had shown significant, just 50 patient of the number of patients to be treated to decrease one cardiovascular death. And if you see EMPA-REG, their only number needed to treat was 46. So it was well and truly behaving something like a cardiovascular medication, and that is how the, if you look at the other data, then the molecules like simvastatin, enalapril, spironolactone, they also decrease the cardiovascular mortality. So it is something which is doing a really good cardioprotection and decrease in morbidity and mortality. If you look at the mortality benefit demonstrated in cardiovascular studies, and there are various studies like candesartan with the CHARM study, SAVE data. So all these, if you look at the reduction in mortality, and if you look at the EMPA-REG outcome data, this is giving competition to all other molecules data, and meaning thereby that this is one molecule which not only works in the decrease in the heart failure hospitalizations, but clearly this is one of the most robust group of molecule which decreases the all reduction in all cause death compared to placebo. So that is the power of this molecule, and this is something which was startling the medical community, that how can a non-cardiac drug, basically anti-diabetic medicine, will have a so much powerful effect on the cardiovascular mortality and also all-cause mortality. So that's also quite impressive. So let's dig a little deep that the mortality reduction observed in EMPA-REG outcome data, how robust was that? And if we compare with the other SGLT2 inhibitors, so is it just a class effect? And if it is, then definitely all molecules would have similar range of reduction in cardiovascular mortality. But if you look at the EMPA-REG data, CANVAS data, and DECLARE-TB3 data, which was with dapagliflozin, CANVAS was with obviously canagliflozin, and EMPA-REG with empagliflozin, and you can see that cardiovascular death was 38% reduction vis-a-vis. If you look at the Canvas program, there was hardly any significant reduction. If you look at the p-value, that was not significant. And then the declared TB 58 data also did not show significant reduction in this. And the second all-cause death, again, that was pretty impressive. With EMPA-REG, you could see 32% reduction vis-a-vis the other two classes of this SGLT2 inhibitor with the Canvas program and with the declared TB dapagliflozin and the canagliflozin. This was not there. So that is why people felt that probably some of the things are class effect, but it's not entirely the class effect, and that's the reason why empagliflozin has such a robust data. So then look at the MACE outcome from SGLT2 inhibitors in cardiovascular outcome data, and you can see that the declared TB data, Canvas data, and EMPA-REG outcome data, you can clearly see that the EMPA-REG data did show significant, benefit compared to the placebo, whereas the other two molecules you could see it is on the midline, whereas the maximum benefit was with the empagliflozin. And then if you look at the all-cause mortality outcome and compare with the three major molecules, that is canagliflozin, dapagliflozin, and empagliflozin, you can see clearly the winner is empagliflozin if all-cause death outcomes are concerned. So definitely there is some class effect, but well and truly the empagliflozin is a clear winner by miles if you look at the cardiovascular and all-cause mortality. Then if you look at the patients with established cardiovascular disease only, so one of the criticism of EMPA-REG data was that in this trial, the patients who had established cardiovascular disease like heart failure or post-myocardial infarction, and that is why the benefit was so robust. But it's not true. If you look at the people who have established cardiovascular disease, you can see the EMPA-REG outcome, there was 32% relative risk reduction, whereas in Canvas program there was no significant relative risk reduction, and similar was with the dapagliflozin. So definitely we can clearly say that despite some of the class effect, the empagliflozin has significant relative risk reduction as compared to the other two molecules in patients who have got established cardiovascular disease, meaning that by the people who have got heart failure or post-myocardial infarction. And if you compare with the cardiovascular death outcome from SGLT2 inhibitor cardiovascular death, again the EMPA-REG outcome data clearly makes the empagliflozin clear winner compared to the other two molecules. And then similarly, if you look at the consistent, in various sensitivity analysis, the cardiovascular death finding, again you can see that the EMPA-REG analysis 1, 2, and 3 analysis, in all three analysis, there was more than 38% reduction, relative risk reduction. There was again 41% relative risk reduction in cardiovascular death event per 1,000 patient years. And then in analysis 3 also, this is similar finding, even more robust, 40% relative risk reduction was there. If the patient with established cardiovascular disease alone, the effect was again with the EMPA-REG much better compared to the other two molecules. Then if you look at the consistency in patient across the all cardiovascular spectrum, similarly you could see that the patients who have got heart failure, overall study, the relative risk reduction was 38%. Patients who have got heart failure, there was again 35% risk reduction. Patients with cardiovascular with intermediate TRS2P score was there, also 37% relative risk reduction. And patients with cardiovascular disease without prior myocardial infarction, there also you could see that there was 35% relative reduction in cardiovascular death events. So that all the groups had significant relative risk reduction. Then in patients with CKD, you could see that because as per the recruitment of the patients in this trial, the patients who have got eGFR more than 60 mils, that was only taken. So you could see that in there also the progression of overall study progression did show that the cardiovascular death events were significantly lower, 38% relative risk reduction. Patients without CKD compared to the patients who had CKD. So in all these group patients who had whether CKD or not, the cardiovascular relative risk reduction was significantly lower. Then if you look at the extent across the type 2 spectrum, cardiovascular death and heart failure benefit in SGLT2 outcome data, again you can see that this is the midline, and in all these when you take all the SGLT2 inhibitor in Canvas program or Declare, definite benefit was there, but the EMPA-REG outcome data with empagliflozin, if you look at the hazard ratio, that was favoring much strongly for empagliflozin. And then patients with a history of heart failure, again, you could see that all the SGLT2 inhibitors were doing wonderfully well. And patients with no history of heart failure, again you could see that the patient who never had an heart failure had again clear benefit with the SGLT2 inhibitor, but definitely the empagliflozin was clear winner in that situation as well. Patients with established cardiovascular disease only, you could again see that definitely because of the class effect, Canvas program had some lower benefit, and the Declare TIMI data did show that with the dapagliflozin it was still lower. So definitely it's not all the class effect. Probably there is something more in empagliflozin which is doing these kind of better outcomes. If you look at the heart failure hospitalization outcomes with the SGLT2 inhibitors, you could see that there the class effect is more robust. You can see that the significant decrease is almost all across the group of drugs. So in patients who have got significant heart failure, so simply because of the intravascular volume decrease, so what we call, and the energy utilization by the myocardium also becomes better with the SGLT2 inhibitor. So that is why all the SGLT inhibitors are doing better. But still, if shade better is the empagliflozin compared to the other SGLT2 inhibitors. And again, if you look at the heart hospitalization, because the heart failure events, again there is a significant reduction, but here all the other two molecules like canagliflozin and the dapagliflozin, they are also doing really well. So benefit of dapagliflozin on cardiovascular death or heart failure outcome was given only because of the hospitalization and the heart failure was significantly reduced in dapagliflozin trial, and that is why you did not see the cardiovascular death reduction or the overall cardiovascular death in dapagliflozin trial. So that is, this is to counter from the empagliflozin group of people that, it's not that all the molecules are same. So similarly, you could see that the reduction in cardiovascular death as well as heart failure with empagliflozin as observed in EMPA-REG outcome data, you can see that here all of them are statistically significant in favor of empagliflozin. So I think we should welcome Dr. Khullar, who has just entered like a star here in this hall. So give him a big hand. So if you, continuing with the same theme, if you look at the consistent cardiovascular mortality benefit with empagliflozin regardless of heart failure burden, this cardiovascular mortality reduction with empagliflozin was significant and consistent regardless of heart failure burden. So that's a very big statement, because you don't really need heart failure, even the coronary artery disease and the other cardiovascular events would be significantly decreased if the patient is taking empagliflozin. Whereas if the patient has existing heart failure, then only the cardiovascular endpoints will be significantly improved in patients who are taking dapagliflozin or those who are taking the canagliflozin as well. So are the results of EMPA-REG outcome applicable only to the benefits of type 2 diabetes who had past history of MI and stroke? The answer is no. If you look at the patients who have got single vessel disease, multi-vessel disease, history of myocardial infarction, and you compare all the groups, because if the patient had single vessel coronary artery disease or none, then also the benefit is in the similar range. If the patient has multi-vessel disease, then also the event rates are similarly decreased, and you can see all across the board the hazard ratio is significantly in favor of the empagliflozin. So the patients who have got peripheral vascular disease, there also, as you remember, the canagliflozin had gone into disrepute because the higher incidence of the amputation and all. But in all across, even the stroke group of patients, the empagliflozin did really better. So it's not that the established previous heart attack patient and heart failure patients would only benefit, but the patients with all these groups would be benefiting significantly. And similarly, if you look at the lower limb amputation, as I said, the Canvas program, canagliflozin, it had got a black box warning that this is something which is causing, that was a warning. But if you look at the empagliflozin, that was significantly neutral compared to the canagliflozin. And bone fractures, again, the safest of the three class molecules. So definitely we can say that it's not all the class effect. You could see that the empagliflozin did show neutral effect, whereas the other two had. So if you look at the management of hyperglycemia in type 2 diabetes patient in 2018, and to that consensus statement also did show that we need to place this molecule somewhere in the group of patients who are taking, diabetic medications. And if we feel that we have to decrease the cardiovascular outcome, then we need to add SGLT2 inhibitor at some point in time. And we need to, when the patient has established cardiovascular disease, then definitely you can see all the groups shows that the SGLT2 inhibitors would be something which must be added. And those patients who have had established cardiovascular disease, or in patients who have had MI, heart failure more so, they will be benefiting maximally with this molecule. So we must start in this in these patients. And now the data with the renal safety profile and delaying the renal end-stage renal disease is again a big plus point with this molecule. So definitely we should be giving in renovascular patients also. Obviously Dr. Khullar is going to discuss this in much detail. So it is though costly, but if you look at the cost effectivity, that is quite strongly favoring this. So we can say that the proven cardiovascular benefit has quite strong data, and we need to be aware that SGLT2 inhibitor vary by region and individual agents and regards to indicated level of EGFR or initiation of the continuous use. And all the SGLT2 inhibitor have shown reduction in heart failure and to reduce the CKD progression in cardiovascular outcome trial data, which I think Dr. Khullar will again elucidate in more detail. And whereas GLP-1 in end-stage renal disease reduction, we have to be more cautious. And the choose later generation of sulfonylureas when we are using this to lower the risk of hypoglycemia. And one of the beauty with this molecule is that the risk of hypoglycemia will be significantly lesser. So when we are choosing the our anti-diabetic medications, it is not just controlling the sugar, because with what agent we are controlling the sugar, that is also important, because that translates into the cardiovascular mortality and even all-cause mortality and repeated hospitalization as well. So if you look at the empagliflozin consistently reduce the cardiovascular mortality independently of controlling the HbA1c, blood pressure and LDL cholesterol. So the beauty was that unlike the other molecules where in order to get a benefit you need to control the blood sugar more strictly, but here is a molecule which whatever the HbA1c level is, the cardiovascular death hazard ratio is significantly favoring this molecule. So you have just given this molecule, even if the blood sugar is not controlled, but also whatever the reduction is there, the cardiovascular mortality benefit would be, patient would be getting with that molecule. So that's the beauty. It's not like insulin and all where, you need to significantly decrease the blood sugar and then only the end point of the cardiovascular mortality will be lesser. So this is what I was referring to, that whatever the HbA1c level is there, the patient is going to get significant benefit, but obviously we need to control the sugar in toto. So that is why the 2018 ACC expert consensus decision also, they have also said that whenever we are thinking of cardiovascular protection, we must add SGLT2 inhibitor or GLP-1 RA analogs to decrease the atherosclerotic cardiovascular relative risk reduction. But definitely there is no other choice if the patient has got associated what we call heart failure as well. So SGLT2 inhibitor empagliflozin is currently preferred simply because the data is so robust, and especially in established cardiovascular heart disease where the patient's mortality, hospitalization, all-cause mortality and cardiovascular mortality, everything goes down significantly lower. So to conclude, friends, ladies and gentlemen, I would say that the evidence from SGLT2 inhibitors cardiovascular outcome data suggests the mortality benefit associated with empagliflozin and the MACE benefit with empagliflozin and canagliflozin in patients with type 2 diabetes with cardiovascular disease. The cardiovascular mortality benefits of empagliflozin extend across the spectrum of cardiovascular disease in diabetic patients. Remember, there would be sooner a trial in patients who have got just cardiovascular disease and not significant diabetes also. And in all groups, whether the patient had MI, stroke or peripheral vascular disease, this is going to have a much better outcome. And then, it can be used as a first line add-on to metformin in patients where there is some talk also about early diabetes reversal with these agents, but that's not yet been proven. And optimize the clinical consideration of risk benefit for such each anti-diabetic agents in principle of individualized approach. So, meaning thereby that now we cannot give any anti-diabetic medicine to our patients just to control the blood sugar, but we have to select a molecule which decreases the cardiovascular mortality and repeated hospitalization as well. And as of now, what the literature suggests that there is no better molecule in this group as the SGLT2 inhibitors, and more so if the heart failure is not there, to decrease the other cardiovascular endpoints, the best of the lot is empagliflozin. So thank you very much for your kind attention. And if there is any question, we'll take it.
Empagliflozin. May I invite Dr. Dinesh Khullar for his talk? Dr. Dinesh Khullar is the Chairman Nephrology at Renal Transplant Medicine at Max. The DM Nephrology from PGI Chandigarh, and prior to working at Max, he was there at Gangaram Hospital. Actively involved in academics and research. And in areas of interest that diabetes would be elaborating on SGLT2 inhibitors with respect to renal outcomes and with specific focus on empagliflozin and vis-a-vis the other two molecules which are available. Dr. Khullar, please.
It's a pleasure to be here amongst you always, and I can't thank Dr. Johan enough for these repeated opportunities which I get to interact with you. The ball has been set rolling by Dr. Viveka already, and I must admit that we are very excited about what SGLT2 inhibitors have shown us in terms of data in the recent years. There was a lot of skepticism when we first set about using this wonderful class of molecules, and I'm sure that still exists somewhere in our minds when we start thinking of using SGLT2 inhibitors in our given patients. And this apprehension was even more when it came to the usage of SGLT2 inhibitors in patients with renal insufficiency. And let me remind you that the basis of the action of SGLT2 inhibitors was taking into consideration that the kidneys should be working normally. The GFR should be normal before they could have any kind of action. So, compromised. And as we will see when we recapitulate our knowledge of renal physiology, one would tend to believe that this class of molecule will not work if the GFR falls down. So initially we were stuck at normal GFRs. Then came a time when we were told that they may be working even at a GFR of 60. Still later came a stage when we were told that maybe they are functioning well enough even at CKD stage 3A, that is GFR 45. And now of late, what we have recently seen, the trial of the very famous, eagerly awaited trial with canagliflozin, the Credence trial, results just came in. And we realized that it was functioning quite well, even at a GFR as low as 30. And let me tell you, the bar has been set even lower. I am involved in the trial with dapagliflozin to GFR as low as 25. It's still underway, and the way we were eagerly awaiting the results of Credence, we are now awaiting DAPA CKD, and finally we'll have AMPA CKD still later to follow. And what is more interesting in DAPA CKD is it is just not the diabetics that we have taken. We have even enrolled hypertensive, non-diabetic. So we are exploring the role which SGLT2 inhibitors can play, not just in diabetics, but also in hypertensive. So we will recapitulate, as I said, our knowledge of SGLT2 inhibitors and try to see what we know about the mechanism of action of this wonderful class and many things which we still do not know and are yet to explore. So, first and foremost, I think there's severe renal impairment, that is the GFR. Once we wake up to the reality of some kind of renal insufficiency, that is stage CKD stage 2, by the time GFR is less than 60, it occurs in 20 to 30% of patients with type 2 diabetics. 49%, roughly 50% of patients with more advanced eGFR less than 30 ml eventually progress to end-stage renal disease. 30% of patients with macroalbuminuria progress to end-stage renal disease. So it's just not having diabetes. We know there are about 10 crores of people within this country having this. Imagine 40% of these getting some kind of diabetic kidney disease. And look at what happens. Once they have GFR falling to less than 60, look at where they are heading towards. So we know that we are not heading in the right direction so far. And whatever we have in our armamentarium probably is not good enough. And we in South Asia are even worse affected. Why? Because we have fourfold more likelihood to develop albuminuria. We have roughly 1.5 times higher loss of GFR, that is, our patient's rate of progression is much faster than the counterparts in the Western world. There is a higher prevalence of more advanced CKD. So I do not know how will we be able to cope up with the tremendous burden of more advanced stages of chronic kidney disease related to diabetes. And unfortunately, this is what's happening. When it comes to Dr. Viveka's field, they are much better off, and I think full marks to them the way they have tackled the menace of the problem in their patients. But if you look at end-stage renal disease, it's rock solid. Here at this level, refusing to budge. So as I said, admittedly, we are no better off than what we were many years ago. Now this is equally important. This is what brings me to my dear friend closer. Every time you would see us hammering down everyone's mind as to why the complications of diabetes are important, and in particular what they do to the heart and to the kidneys. The number is projected to double. The number of people requiring renal replacement therapy is likely to double up by 2030. And what is interesting to note is that if your patient gets early CKD, he loses about 6 years of his life. If he has just diabetes but no kidney disease, he loses maybe 10 years. But it is a sum total of these two entities. If he has even early diabetic kidney disease, loses about 16 years of his or her life. And equally dismal is the performance of the patients who are put on dialysis once they have advanced renal failure. We always are scared of the word cancer, but as you can see here, breast cancer, prostate cancer, even colorectal cancer fares better than people put on dialysis here in yellow. So we may always believe that, okay, it's renal failure, it's becoming more and more advanced. So what big deal? We have dialysis, we have transplantation to our rescue, but this is what you have here. The final outcomes are very poor. And even more worrying is that all these years we were told that ACE inhibitors, receptor blockers have finally come to the rescue of our patients. We have been hearing that, everyone in this hall has been hearing the fact that RAS blockade is a wonderful thing to do. So far, we knew that the only proven treatment for renal protection in type 2 diabetics is either ACE inhibitor or receptor blockers. But would anyone agree that they were enough? Certainly not. Because right in front of our eyes, all these patients have landed into more and bigger problem. And if you look at what has been added to the armamentarium in the last so many years, here in 1980s, you first heard about beta blockers and hydralazine doing something to the chronic kidney disease in our patients. And then finally, this is what I was talking about, with the advent of ACE inhibitors, captopril era certainly made a difference. But that difference was not enough. But what is even more frustrating is hardly anything added to the kitty in the last 17 years. So everyone in this hall agreed, but more importantly, we as nephrologists, because people were coming to us with expectation that maybe we are going to do something which others could not. And admittedly, we were not able to offer anything. So we were desperately seeking a newer class of drugs. Now, this is another thing. Many things came. We postulated that this could be the things going wrong in our patients with diabetes. That is why they were having more and more advanced renal failure. So they tried to hit at the PKCB inhibition. They wanted to do something to endothelin antagonism. I'll come back to that. Then there was pirfenidone taking care of TG beta production. But let me tell you, you try and do something to something which is so protective, the whole body will go for a toss. Sulodexide, then of course we burnt our fingers with dual ACE inhibitors, dual RAS blockade. We had the renin inhibitors coming in and going out without any impact. And then finally we had bardoxolone methyl also, not able to do anything. Why I say I'll come back to Centon is because this was the original endothelin antagonist, did not do much. But as you may have heard recently, there was the SONAR trial data presented at Melbourne, where Credence trial data was also presented. That's the newer class of endothelin antagonist, atrasentan, which has been shown to have some effect. So we are yet to hear more about atrasentan. Till then, let's limit our focus to SGLT2 inhibitors, and as you can see, I am quite excited about what they have shown us. Well, the problems in our patients and the challenges which we face while treating diabetes in patients with chronic kidney disease is the inherent problems of oral drugs, which you are all familiar with. On one hand, you have a lot of unpredictability of the way a given oral drug is going to behave, but at the same time, if you try and attempt achieving an HbA1c of less than 7, this is what happens. A 30% increase in my patients going to Dr. Viveka. Why? Because of an increase in arrhythmogenic cardiomyopathy, a 40% increase in cardiovascular death. So either kuan, either khai, whatever you call that, but we are desperately looking for something which is better than what we have at the moment. And in this context, let's talk a bit about SGLT2 inhibitors. Well, let me draw your attention to something which I may have shown you in my previous interaction with you, but this is a very famous, a very popular, or my favorite slide. As you can see here, diabetes causes glomerular hypertension. How? Well, as you can see, in diabetes there is upregulation of sodium and glucose transport. Now, upregulation means the glucose and sodium which has filtered out of the glomerulus is passing through the proximal convoluted tubule. Look at what happens when there is upregulation of the sodium and glucose transporter which is sitting in the proximal convoluted tubule. You can see here, with this upregulation, most of the sodium and glucose gets reabsorbed. Hardly any goes to the macula densa. Macula densa says nothing is flowing in to me, so it sends a bad signal. this is like a dam sitting here. So it sends a signal to the afferent arteriole saying that nothing is reaching me, please send in something more. And that is when afferent arteriolar dilatation occurs. There is increase in flow to the glomerulus, and finally you have increased GFR. When your patient first became diabetic, this is what you get, increased GFR. And this is the time when we may feel very happy that patient's GFR, rather than being 90 or 100, is 120, 30, but the seeds have been sown here. So that's the culprit. We always ignored probably this important mechanism of action. And now let me draw your attention to what happens when you combine, when you give your patient SGLT2 inhibitors. Now you see, the SGLT2 inhibitor is blocking the transport here. So nothing comes out, more and more passes into the lumen up to the macula densa. Macula densa sends a signal back to the afferent arteriole, shut the gates please, enough is enough. And that is when afferent arteriolar vasoconstriction takes place and reduction in the flow to the glomerulus, and finally you have a decreased GFR. So you may wonder, why are we happy about reduction in this GFR? Well, this is not a normal reduction. This is bringing back an abnormally elevated GFR to its normal value. So you will always expect some degree of reduction in the GFR when you first give SGLT2 inhibitors. Something similar what was happening when you first gave your patients ACE inhibitors or receptor blockers. There, rather than afferent arteriole, the mechanism of action was at the efferent arteriole. So, moving on. With this, why are we worried with this hyperfiltration? We were worried in this hyperfiltration because of Dr. Brenner's, of whose textbooks we all have read while becoming nephrologists. He came out with a wonderful theory of hyperfiltration, whereby he said, when you have kidney damage, there are loss of the nephrons, there is a reduction in the function, and you will have the remaining nephrons will have to work harder. There is hyperfiltration of the remaining remnant nephrons, resulting in glomerular hypertension, and then finally what they say, injury begets injury, and further loss of remaining nephrons. As you can see here, the chimneys, the kidneys sitting and sending out fuel, normal kidneys, GFR normal, and working quite beautifully. Because their anti-hyperglycemic effect is independent of beta cell function and or insulin resistance. So we are not bothered about what pancreas is doing at the moment, how it is behaving. We are focusing what this class of molecule does at the level of the kidneys. And of course, you will have the improvement in hyperglycemia as a result of SGLT2 inhibition. There is a lowered plasma glucose. What you see in your patients is the weight loss, improved insulin sensitivity via their effects onto the liver, improved hyperinsulinemia, and of course, it's just the one aspect of the function of SGLT2 inhibitors. But more important is the renal-cardiac hypothesis. We never thought that SGLT2 inhibitors were really going to be very useful in patients with kidney disease. We woke up to this reality via EMPA-REG. In 2016, EMPA-REG was the first trial which said, even though that trial was meant to address the issues of people with heart disease, post hoc analysis showed that they were probably even better for kidney protection. So we have reasons why the SGLT2 inhibitors have a dual mode of action, protecting both the heart as well as the kidneys. We can discuss that if time permits. Now, I would like to draw your attention to the left side of this slide. Here is a type 2 diabetic patient whose kidneys have to do more transporting work, and this is because of the SGLT2 inhibitors, SGLT2 receptor mediated glucose reabsorption. There is unfortunately renal hypoxia here, and there is progressive renal dysfunction. If you add an SGLT2 inhibitors to this patient's treatment schedule, what you will have is an improvement in renal oxygenation and something good resulting to the kidneys. This is what I was talking about. The results, the mechanism of action of SGLT2 inhibitor is multifactorial. They have their actions mediated via the glucose which they allow to be passed out in the urine, as well as also the natriuresis which results as a result of as an effect of SGLT2 inhibition. On one hand, you have effects onto the heart, improving the atherosclerosis and the cardiac contractility. On the other hand, you have reduction in intraglomerular hypertension and resulting in a dual cardiac and renal protection. There are effects of SGLT2 inhibitors which are both direct as well as indirect. Via improvement in glycemic control, this is what you ordinarily would expect in any anti-diabetic agent. But what is interesting are the direct effects at the level of the kidneys, as we have talked about, their effects on the intraglomerular pressure. Equally important is what they do to mitigate the inflammation at the level of the kidneys by taking care of the reactive oxygen species and reduction in the toxicity of glucose. Very interesting to note that they cause an improvement in blood pressure. They are not just like any ordinary diuretic, because there is some diuresis which occurs with SGLT2 inhibitors, but how they are different from a traditional diuretic is they cause a reduction in uric acid as compared to an elevated uric acid levels which you experience, which you find in your patients who have been put on thiazides. So with this background, now let's try to see what EMPA-REG showed us for the first time. And I would like to admit the fact that my interest in SGLT2 inhibitors was kindled by the EMPA-REG trial, nothing other than EMPA-REG trial, because I'll show you why. There was found to be a reduction to the tune of 44% in the risk of doubling of serum creatinine, even when the GFR was less than 645. The time to first initiation of continuous renal replacement therapy or dialysis got reduced by 55%. You're not talking about 2, 4, 5 or 10%. You're talking about mind-boggling figures. The hard renal outcomes, and we typically as nephrologists talk about doubling of serum creatinine, initiation of renal replacement therapy, or death due to renal disease at the hard composite endpoints and renal outcomes. They were found to be reduced by 46%. And there was, of course, one could expect regression from macroalbuminuria to even normoalbuminuria, forget about microalbuminuria. So all this while we were under the impression that once the stage of overt nephropathy sets in, nothing can bring back the protein excretion back to normal. But here was a class of molecules which was actually doing that. So to summarize of what EMPA-REG had shown us, that there was a tremendous benefit of what SGLT2 inhibitors can do. But mind you, EMPA-REG was not primarily focused for the kidney patients. It was for the cardiovascular outcome. It was in CVOT. So it was meant to look at what SGLT2 inhibitors were doing to patients with heart disease. So we obviously needed to have a dedicated trial. And that is when people came out with, of course, Credence to begin with. So we are equally excited about the data of Credence. We'll talk about that in a short while from now. And as I said about DAPA-CKD and EMPA-CKD as well. So this point I've already highlighted that empagliflozin, in contrast to a routine diuretic, actually reduces serum uric acid levels. Now this is a class effect. It's not as if empagliflozin, of course, we are indebted to empagliflozin because this was the first of its class which showed the tremendous benefits, but that does not mean that the other SGLT2 inhibitors do not reflect the similar kind of situation. As you can see, canagliflozin versus sulfonylureas at the end of 104 weeks showed that the results were inferior, as shown in yellow, when a patient was given glimepiride as compared to 2 different doses of canagliflozin. Now, the same was seen with dapagliflozin as well. Now, all these people who were enrolled with Canvas trial or EMPA-REG were people who were here in this category, where, as you can see, it's a very safe zone from the kidney point of view. GFR between 60 to 90 and hardly any albuminuria. Now, I would again like to draw your attention. This is how these days we talk about a given patient's kidney status. As you can see, this is stage 1, 2, 3, 4 and 5. And this is A1, that is no albuminuria, some albuminuria and too much of albuminuria, A1, A2, A3. So if you have to qualify your statement, you will say, when I say that my patient has G2, A2, that would mean that the GFR is between 60 and 90 and the albuminuria is between 30 and 300. So this has taken away a lot of ambiguities when we want to focus on what kind of kidney function our patient has. But as you can see, all these trials, the DECLARE, TIMI, the results of which came out about 6 months ago, Canvas, EMPA-REG, were having people with fairly good GFRs and hardly any albuminuria. And we certainly wanted to see what happens if we give these drugs. If the patient's GFR is already compromised, patient has albuminuria, and that is why credence is important, because credence had specifically looked at people who already had significant reduction in GFR and significant proteinuria. So if they were able to show in their patients by giving 100 milligrams of canagliflozin versus placebo, and of 4,400 finally randomized patients, equally two arms of placebo versus canagliflozin, if they could show that there were significant effects on the HbA1c, on systolic blood pressure, on body weight, on albuminuria. Now this is what we are wanting to see in a patient who has some proteinuria. So let us see what were the primary outcomes. As I said, the results were released at the World Congress of Nephrology in Melbourne just about a week ago. As you can see, the primary outcome was to see if we could see any reduction in the primary hard endpoint, composite endpoint, that is these three: end-stage renal disease, doubling of serum creatinine, or renal or cardiovascular death. And look at what credence has shown. In placebo, it was seen in 340, while in the canagliflozin arm, just 240. And look at the hazard ratio reduction, 0.70. That means 30% risk reduction if these patients were given SGLT2 inhibitor. Same about if you excluded cardiovascular death and looked at the other three components, hazard ratio was even more importantly reduced. That is 34% risk reduction. In end-stage kidney disease, the risk reduction was again about 32%. In the need for dialysis, transplant or renal death, again there was a risk reduction of 28%. So this was to summarize. In all parameters, canagliflozin was shown to be far superior to placebo. In terms of the effects on GFR, again, as you can see, the yellow drops to significantly lower values as compared to canagliflozin in the blue line. So to summarize, what credence has shown us is that there was a reduction in the risk of primary outcome of end-stage renal disease, doubling of serum creatinine, or renal or cardiovascular death by 30%. A very, very significant figure here, as you can see from this p-value. It also was shown to reduce the risk of secondary outcome of end-stage renal disease or renal death by 34%. And even similar reductions were seen in the risk of reduction of end-stage renal disease or requirement of dialysis, transplantation, or patients dying of renal death. Now, this is what I was saying. Credence is just the beginning. We are going to have the results of DAPA-CKD. It's a bit close by the end of next year and maybe another year after that to know what DAPA-CKD has to show us. Similarly, empagliflozin kidney, this thing is even the most, the biggest trial till date, comprising of about 5,000 patients. So this is to summarize. I have tried to bring home the point that SGLT2 inhibitors are good, and I think you in this august audience have been using SGLT2 inhibitors probably more than what I have done, because our choice becomes very limited when patients come to us with more advanced renal failure. But what is interesting to notice that they have been shown to be efficacious even when the GFR has fallen to as low as 30. And we are about to come across what DAPA-CKD tells us when the GFR as low as 25. People were enrolled with GFRs as low as that. So again, some practical take-home messages. When should we ideally avoid or delay the initiation of therapy with SGLT2 inhibitor? Well, if you have an acutely decompensated heart failure in your patient, you should first rely on diuretics, stabilize these patients before you put them on SGLT2 inhibitors. Now, dynamic volume status outside of research. Now we may be doing a research trying to explore some aspect of SGLT2 inhibition, but this is ordinarily not to be done till we have more data on that. If your patient has history of diabetic ketoacidosis, history of recurrent or severe UTI, I'm sure I've deliberately not touched upon the side effects of SGLT2. I think we'll leave that to discussion, but everyone in this hall, I'm sure, knows that when you talk about SGLT2 inhibitor, the first thing which comes to your mind is either genital infections, urinary tract infections, some incidents of amputations, fractures, ketoacidosis, hyperglycemias, but most of these fears are unfounded. Genital infections, yes, they do happen, increased incidence, but not enough to prevent you from continuing with the therapy. Only if it becomes really, really very troublesome, you would want to withdraw the therapy in your patients. CKD stage 4, as I said, till the time we get to know what these new trials and underway trials have to show us, we are not supposed to put any patient on SGLT2 inhibitors if the GFR is very low, if they are in CKD stage 4. So with that, I conclude. Thank you very much for your patient hearing and
fear as to how something which is the pathology of a disease can be made into a physiology and may be beneficial for for all these things that we have said, but it has gone on to prove most of us, all the skepticism wrong, and has found a very, very definite place in medical practice. And also the takeaway from Dr. Viveka's presentation, apart from the CV outcomes that he alluded to, he very significantly mentioned that the comorbidities and the clinical situation should guide the initiation of the anti-diabetic agent. Other than that, Dr. Khullar sir has presented very, very masterfully as to how the bar has been set low for the usage of these molecules at certain, even a lesser level of the GFR. And certainly these are very exciting times because we may have something which could offer much more to the patient in coming years. Anything?
Two things were brought out very clearly and ever since HEMPA read. One is the first major drug, the anti-diabetic drug, which is bridging the gap between micro and macrovascular complications. Even insulin could not do that in UKPDS. Another wonderful thing which you brought out today wonderfully and actually overemphasized by kids is the microvascular, the renal outcomes. So now we have a drug actually which is not only acting on the macrovascular front but also on the microvascular front. So do you think we have found the ultimate answer to everything that we needed for diabetes? Your comment, sir.
I won't say ultimate answer, but then as we could I'm sure you had seen, going by my enthusiasm today, that we have certainly found something which takes us in the right direction. And I don't know whether I shared with you the last time I had maybe presented the data. This is very close to my heart because I was actually, during my college days, medical college days, made a laughing stock of what I had said once in my class when we were being asked that by the professor, how do you think we should be tackling diabetes? Because even we knew that this is going to become an epidemic. So everyone was trying to target pancreas or the peripheral resistance. And I, in my innocence, had said, well, why we should try to aid nature. Nature is wanting to get rid of the extra glucose through urine, by glucosuria. Why don't we make a drug which enhances this? And let me tell you, I was certainly a laughing stock for just about a month. Now, recently I had gone back to my medical college and I singled out each one of whosoever I could see in the audience and pinpoint that you had probably instructed our best contractor, Madan Lal ji, Dr. Sahab ko naam logon khilaiye, inka dimag bahut chalta hai aajkal. So I wanted to hit back with a vengeance. But this is something which had stuck for many years. And this is actually a very honest statement. People came to us, nephrologists, seeking an answer which the general physician was not able to give them, trying to slow down the production, and honestly speaking, there was nothing more. I mean, we were expecting a good physician to already have started them on ACE inhibitors or receptor blocker. What extra was he doing in these patients? Just watching them going from stage 2 to 3 to 4 and finally welcoming them in the dialysis room. So, I'm not saying SGLT2 inhibitor is going to put a full stop, but when you combine, and there was a very interesting slide which I deliberately did not show because that concept is now a little older. There was a time when people said, why don't you combine ACE inhibitor, receptor blocker and SGLT2? You are taking care of the efferent arteriole by releasing the obstruction and you are shutting the gates of the afferent arteriole. Even though everyone would realize the fact that if you stop blood coming from the afferent and allow whatever blood flows into the glomerulus out of the efferent, there will hardly be anything left in this room. So there will be a drastic reduction in GFR. But the practical scenario has not shown that. And Credence trial and Dapa-Security trial is enrolling people who have already been given a maximally tolerated dose of ACE inhibitor and SGLT2 inhibitors over and above that. So your point is very valid. But we are exploring more and more. We are going to have sinocertin, we are going to have ASK1 inhibitors. So different, as I said, atrasentan, the endothelin antagonist. So maybe one day we will have maybe 4 or 5 different molecules targeting the physiology, pathophysiology at different areas and doing some good to our patients.
Sir, the caveats to be followed in initiation, as sir mentioned very beautifully in the last slide. Take care of those and I think you are very safe.
Sir, with Amperide, we had borderline GFR of 45. We were not using it below 45. Although the trial originally conceptualized using it in people between 60 to 90. But even people who had an eGFR of about 45, even they were included in the trial. Now in Credence, I believe they have gone as low as 30, you mentioned. My question is different, sir. Suppose we use it now, since there are such good effects and there is an improvement in kidney functions, why don't we use in people even below 30? What is inhibiting us from doing that?
Yeah, so that's a valid question, and the apprehension in everyone's mind was, for the drug to have an effect, there has to be some GFR to take this drug to the kidney. And if that indeed was the case, if the kidney was not functioning enough, if the drug was not reaching the tubules and affecting onto the sodium glucose transporters, it did not have an effect. So that was our hypothesis. We were proven wrong. It was shown to be effective even at 45, at 30, now with Dapa-Security at 25. I won't be surprised, as you had said, at 20, but we don't have the answer to that. So if it works, you see every year of reduction of not allowing your patient to reach end-stage renal disease. Look at the tremendous good you have done to the family by preventing dialysis for a year or maybe 2 years or 3 years.
I would also request all of you to ask some questions. Okay, so that would be.
This is very early. So how do you achieve that with the SGLT2 side?
Very interesting, and I think that probably reflects on the actual mechanism of action. Let me admit the fact that probably we do not really know for sure how do they work. There are a lot of postulations, but we are yet to find out the real mechanism of action. But the albuminuria is directly related to hyperfiltration. So what the drug does at the most initial phase is reduction in the hyperfiltration. So since hyperfiltration is going to sequester out albumin through the tubules, through the glomerular central tubule, anything which causes the reduction at the intraglomeralar hypertension is a welcome thing. So very interesting. But to have seen that occurring within 12 weeks was an eye-opener.
So, in short, these drugs reduce intraglomeralar pressure by 6 to 8 millimeters. This seems to be the best mechanism for its early response. What about the dilatation of the efferent arterioles?
Efferent, you said?
Efferent.
Yeah, because you see, they are going to close down the afferent arterioles so that not much will flow into this room. So I always give people example that we are sitting in this room which is glomerulus and we have to take care of the pressure in this room. If we close down the gates, that is the afferent arteriole, not enough will flow. That is where the prostaglandin or the adenosine or the SGLT2 inhibitors are sitting. On the bacteria driven tubular feedback is sitting. On the other hand, if you open those gates, whatever is here in this room will quickly pass out into the adjacent room. Again, this room will be devoid of any meaningful blood flow here. And that's why we were talking about a combination of this room, closing this room, opening that room via ACE inhibitors or receptor blockers. There will hardly be any flow. So you are right. If it is just 6 to 8 millimeter reduction here, now you open that gate, this 6 to 8 becomes almost like 12 to 14 reduction in the glomerular hypertension.
So 28% reduction in albuminuria. This is over and above the ASAPs, causes extra 18% reductions.
Right.
How true is that, sir? So this is additional, right, sir? So tell us, the Asian patients are more responsive to ACE or ARBs. Is it because of the extra salt that the Asians take?
No, I think it's probably something to do with the renin gene also. So I think
because this also reduces the sodium absorption.
That's very important. And that is
so,
why
mechanism here probably is also beneficial here. See, the SGLT2 inhibitors reduce sodium absorption. So probably this is beneficial here as well.
So that is the reason why we are advocating the use of SGLT2 inhibitors to control blood pressure. We have used it even in non-diabetics. So this is just not any ordinary anti-diabetic. We have used it even as anti-hypertensive,
right,
protecting the kidney.
Right, sir. So my last question, sir. The DAPA-CKD and the EMPA kidney trials will further evaluate even in non-diabetic patients the prevention in heart failure, CV events and the CKD.
True, 30%. DAPA-CKD is enrolling 30% non-diabetic patients.
Thank you, sir.
Because of the sodium mechanism?
Yes, because of the nitrogenesis. So in one hand you have glucose down the drain and that is when you get the cardiovascular outcome improvements. So that's this is how we originally started talking about SGLT2 inhibitors.
Thank you, sir.
Sir, Dr. Khullar, sir, I will ask my last question first.
Yes.
It is related to your last statement. So as you said, sodium and glucose transport. If one is having hyponatremia, so what happens to sodium glucose transport? Is it affected?
So it's better to withdraw, hold thiazides for some time Otherwise, one, you will have higher risk of dyslipidemia. Secondly, you can make your patient's life miserable by giving them two compounding effects with the diuretics.
According to this question,
Also the blood pressure may come down significantly, which should cause much greater problems.
as we are using SGLT2 inhibitors in diabetics because SGLT2 activity is more.
Right.
In a non-diabetic, activity is not more. So in a non-diabetic, in a normal person, suppose I take SGLT2, how will it affect me?
You have a point there, sir. I mean, that takes us back to something which I had shown in terms of renal physiology, that there is upregulation of sodium glucose receptors in diabetics.
Yeah.
And Dr. Kallar's question is, that is understandable that if to such a patient you give SGLT2 inhibitors and there is normalization.
We expect action.
But what you have to understand, in non-diabetics or hypertensive, there is still some activity of sodium glucose. There may not be an upregulation, but some activity of sodium glucose transporter is taking place, which is normal physiological. You are blocking even that. So there is, let's say, the normal is 100. In diabetics, it became 150. In diabetics, you brought it down from 150 to 100 or maybe 90. In hypertensive, you are bringing it down from 100 to maybe 80. So that reduction in the cells, it acts like a natriuretic peptide. A natriuretic peptide, something which is to be seen with a diuretic without having any deleterious effect on the uric acid levels. So that's the beauty.
In simple words, even if one is not diabetic, but is having microalbuminuria or hypertension or renal problems or HF.
Not other renal, sir, I would not have the answer to that.
Why don't you want to give it in a non-diabetic?
Since the studies are on.
Yeah, so once we have the data from that, if they show us that this is it's working
From a microalbuminuria point of view, maybe, but I mean,
Sir, a very hypothetical question. As you said, diabetic loses 10 years and CKD loses 6 years and combined lose 16 years. So how much SGLT2 will regain?
difficult to answer, sir, but I think this is the one step in the right direction. So even if we don't regain 16 years, even if it is 8 years, it's welcome. We would have, I mean, beggars can't be choosers. So,
My last abstract question, sir. As EGFR started, we were starting 60, then 45, then less than 30. Are we going to 15? Is it all pharma driven or is it physiological?
You're right, we don't have an answer to that. But till the time, I mean, even though, as I said, I am the national lead investigator for DAPA-CKD, I am part of the initial data which is coming out. I would not really make any comment at this point. But we will not be able to dispute the data if they come out with a concrete evidence that yes, it helps, it works even at GFR of less than 20. So at least we have another weapon in our kitty or our material to be using successfully.
Sir, I went around the audience. They are just overawed by Dr. Kalra and Dr. Tulsi. I can't help it.
You wanted to ask?
Yeah. So, Dr. Sengupta, is this... of course. So, is this a heart drug or a diabetic drug for the heart?
See, the funny thing is that when it was being, tried out and the sanctioning agencies were on, there was one cardiologist who was all out to give it for as an anti-cardiac drug, whether the 19 diabetologists sitting out there did not want to. But it has turned out to be a wonderful, wonderful drug, both for the outcomes as seen. So, and they are still evolving, but it has definitely come to occupy a place in therapy, as we all know, but keep certain caveats in mind. Obviously, as mentioned, acute cardiac failure, etc. status, you should not be initiating.
Right.
Listen to the clinical statement.
So the second question I wanted to ask was, the EMPA-Heart, published in Circulation November 2018, talked about the LV mass regression and the remodeling. Just a word on that.
See, it has helped in heart failure reduction. Obviously, anything which has been doing it over a period of time, whether you take into account ACE inhibitors or ARBs or this drug, over a period of time when the heart failure status has stabilized, ventricular remodeling could occur, which was initially a negative adjustment, but then would definitely, once things are stabilized, it will reduce LV mass, etc. So over a period of time, the myocardial wall tension, etc., everything would stabilize, but obviously not come down to normalcy.
Right. Thank you, sir. Thank you.
What's your experience with this SGLT2 inhibitors in controlling hypertension?
The ones who have fairly advanced renal failure. So there are people who are already in CKT stage 4 or CKT stage 5. That's a typical patient of ours who we find it very difficult to control the blood pressure of. There we are actually not able to use SGLT2 inhibitors. So the question would be, I think I probably would be able to address that into our patient's treatment if we get the approval of use of SGLT2 inhibitors in people with GFR of less than 20 or 50. Till then, I have not really looked at SGLT2 inhibitors to overcome resistance in hypertension of my patients.
So some of your patients must be having EGFR of 45 like that.
Right.
Even they are having, you are requiring 3-4 antihypertensives.
True.
As such, does the drug really help? What's your opinion?
I don't think, sir, honestly speaking, I have answered to that, or maybe I have looked into that. But DAPA CKD is definitely going to throw some light on that. And that's a very big trial, sir. So I'm sure this is a very valid question, and we are going to hear something from DAPA CKD as per that.
A small comment is very practitioner. SGLT2 inhibitors is a very good drug which is coming in our armory. But I would say as a general condition, it is a good drug for anti-diabetic. We have pleiotropic effect in hypertension, heart disease. But as a first-line indication for hypertension and heart disease, I think this drug has to be weighed and watched to supply with more drugs. That's what my observation.
True, sir. But I think the performance stays same. But I think they have moved up the ladder with this data and with the cardiovascular outcomes and the renal protection. I think many of us believe that their legitimate place now is number 2 rather than number 5 in the list.
Sir, there is a question.
This is there in the ADHD algorithm as mentioned, sir. One question, sir. How often do you use minoxidil as an antihypertensive?
We have to, I just about 2 hours ago, I had initiated a patient in the ICU on minoxidil. So we as nephrologists get to use minoxidil almost like once in a week or twice in a week in our patients. So we have decent experience on how we should be using, but I think the word of advice always is something which we at times tend to forget. We must always put these patients on diuretics first, beta blocker first, and then add minoxidil. Otherwise there could be a problem with reflex tachycardia and with edema, including pericardial effusion, which you can get with minoxidil.
Sir, I got a question from the back. This is regarding SGLT2 inhibitors concomitantly being used with ARNI, neprilysin inhibitors. And both are wonderful drugs now for heart failure. Now which one is doing what, sir?
So again, very interesting. So ARNI, maybe one of these days, Dr. Rao, we can talk a bit about
Thank you, sir.
ARNI.
I'm so happy you are happy, sir.
But that's again because there again I will be probably wanting to bore you with some renal physiology, with what sacubitril does. But the problem with ARNI is not with sacubitril. It is again with valsartan. So if you are confident enough to use valsartan in a given patient, with whatever inherent problems of ARBs are, I think ARNI is a wonderful class. No doubt about it. So
Valsartan is again the ARB which is being used the maximum worldwide.
Wind up. So, as my friend asked about whether it is a diabetic or cardiac medicine, gynae medicine. If you know, it has digoxin. It started as a gynae medicine and it has changed its use 7 times and now it is almost of no use.
So gratefully and a very lively discussion session. Thank you very much.
Doctor.